are the bones longer than wider, like the all the bones of the arm and leg, like excluding the wrist, ankle, and the kneecap. Those things are short bone actually. The bones that are as long as the wide, a cube shaped, are the bones that make up the wrist and ankle. The carpal and tarsal bone are actually short bones. And out of which the carpal bones won't ossify in the fetal period. The tarsal bone actually has some ossification at after 24 weeks. So this is image representation of the long bones, the humerus, radius, ulna, and the metacarpal and the phalanges of the upper limb, and in the lower limb, the femur, tibia fibula, and the phalanges are the long bones. And what are not included in the carpal and the tarsal bones, like these are the actually short bones. So as per ISOP guideline, for mid-trimester ultrasound, the presence or absence of both the arm and hands and both the leg and feet should be documented using a systematic approach. And counting of the finger is not required as a part of routine mid-trimester scan. And here we have to note two things. One is documentation and second is systematic approach. So what are the plans that is required? The plan in the 20 plus 2 plan approach, the limbs examination is based on plan 15, plan 16, and plan 17. So in plan 15, as you see, the femur diaphysis length is measured. In the plan 16, the whole lower limb, including the the two lower limb and all its segment and three bone, the bones and the feet, and the normal relationship between the leg and the foot should be examined. And the plan 17, the both the arms, both the hands, and the normal relationship between the arm and the hand should be examined. So this image is the plan 15, where the femur diaphysis is measured. In the plan 16, the femur, tibia fibula, and the foot is examined. In the plan 17, the humerus, radius ulna, and the hand is examined. So, what are the segments of the bone? The segments of the limb. In the upper limb, the image showing the graphical representation of the upper limb, where the upper arm is the most proximal segment, the lower arm is the medial segment, middle segment, and hand, the so-called extreme part, is the hand, it is the distal segment. And it is another image representing the upper leg, the proximal segment, the middle segment, the lower leg, and the foot. Then how to identify the bones? The proximal segment of the upper limb comprises only one bone, that is the humerus, and the middle segment comprises of two bones, the radius and the ulna. And it is a note that the distal end of the both radius and ulna are ending at almost the same point, but the proximal end of the ulna is somehow higher position than the radius. That means the longer bone is the ulna and the shorter bone is the radius. And in case of lower limb, the same thing. The proximal segment is the has the femur, the one bone, the middle segment is both tibia and fibula, out of which the same happens, the tibia and fibula ends almost at the same level at the distal part, but in the proximal part, the tibia is extending more cranially. That means the length of the tibia is somehow longer than the length of the fibula. And the last distal part is the foot, which is oriented at the right 90-degree to the leg. So the key question are what are the key ultrasound feature of plan 15 and how to image the femur diaphysis? What are the key ultrasound feature of plan 16 and 17? What are the probe movements that are required to image three long bone of all the limbs correctly, and what are the abnormality that can we able to exclude after correct assessment of the plan 15, 16, and 17? So the question is how to obtain the plans. So the baseline is our the plan 14, which is the transverse section of the pelvis and bladder. From that plan 14, when we descend down, slide and rotate to our probe, we will get the plan 15, the femur diaphyseal length. And from the plan 15, when we slide it down and rotate, we will get the plan 16. And for the upper limb examination, from the plane 14, the pelvic the plane, we will go upward, slide upward, and rotate and angulate. But practically, the baby is moving and the limbs are also moving during examination, and this require actually precise movement of the probe to get the planes. So, in overview, what are the requirement from each plan? For each plan, we have to first know what are the things we will look for, and any measurement we will do that is necessary, we will go for that. Third thing, we have to identify any abnormality, and lastly, is the finding pointing towards any kind of skeletal dysplasia or any kind of severe skeletal abnormality. So requirement from each plan is that in plan 15, one measurement we have to make is the femur length measurement. And if the femur length measurement will fall outside the normal range, it may point towards some kind of skeletal disorder. In plane 16 and 17, we have to eyeball whether present or not the upper limb and the lower limb. And if it is grossly normal, a subjective assessment, we do not need to go for any objective evaluation like measurement. But we have to search and see everything. And if it subjectively look normal, that we can rule out from plane 16 the examination of the lower limb, severe skeletal disorder, and the clot of the talus that can be, we can easily rule out. And in the plan 17, the upper limb, we can easily rule out if everything looks normal, the severe skeletal disorder and fixed deformity at the level of the wrist. So what are the key ultrasound feature at plan 15? Plan 15 is the plan for the measurement of the femur diaphysis. So the first important thing is to get a proper image of the femur diaphysis. So as you all aware of the image uh, imaging part from the beginning, so the focal zone should be at the appropriate level to get the correct image of the femur. The femur should fill more than 50% of the image. The whole femur diaphysis should be imaged, and we need.
Amarendra, can you speak a little louder?
Oh,
What do you
okay,
say?
ma'am. Okay.
Please speak louder.
The beam, the ultrasound beam should be perpendicular to the long axis of the femur, and the caliper should be placed at each end of the ossified diaphysis. The longest visible diaphysis should be measured, and any spore artifact at the end of the diaphysis should not be included in the measurement. Here is an image showing the whole diaphysis, and the femur bone is almost horizontal. So the probe is making almost a 90-degree to the ultrasound beam. So this is the best approach, which is called the orthogonal approach. And what we have to measure is measure the anterior and external side. It is the upper femur. We have to measure the external surface of the bone and on the anterior part. So here is the same image. We have to get a longitudinal view of the femur. It is almost horizontal, and make sure that the bone is closer to the probe. That means the upper femur is to be measured. And it is of importance that soft tissue should be visible beyond the each end of the femur. I will explain it. And the bone should not appear to emerge from the skin of the thigh at any point of time. The bone should not be obscured by shadowing, any kind of shadow from the adjacent bony part. So how to assure that we are in the correct plane of section? This is an image, grayscale image showing the femur whole diaphysis, and at the end of the hypoechoic part is the femur diaphysis. And on the each end, we are seeing hypoechoic areas, the labeled as 1 and 3, which are the actually the unossified epiphyseal area, which is not visible in this scanning. So if we are getting both the epiphysis, the hypoechoic area on the both side, that means we had included the whole diaphysis, number one, and it is almost horizontal. So it is the correct plane. So the question is, are we able to see the whole thickness of the diaphysis? In the early phase of fetal life, we will able to see, but in latter half of the second trimester and the third trimester, what is happening? As the ossification progresses, the ultrasound beam will not able to penetrate through the whole length of the diaphysis, and majority of the ultrasound beam will get reflected from the surface of the from the external surface of the bone. So the diaphysis will not, we will not able to see diaphysis in full thickness. Here is the image that is showing the, look for the size of the epiphysis, and the down image is the image of the bone, which is the note the width of the diaphysis that is present, actually real present, and what we are able to see in the scanning. We are able to see the part of the diaphysis on the external surface only. And in the right side of the image, it's showing the epiphyseal ossification center is also visible, depicting it to be a latter half of the gestation, an image of. So in the third trimester, what is happening? We are able to see the spore on one side in this image and one distal ossification center. So we have to put caliper on the external side only. From the with the tick, green tick, we are able to see that is the correct, that will provide us the correct measurement. But if we include the spore, the red cross from the that area, what is happening is it is overestimating the femoral diaphyseal length, because we should not include this sort of spore. So the problem is that if we include, the spore, a problem will happen that this is an image showing the graphical the chart. If we include the only the diaphysis, the measurement is falling within normal range above the fifth percentile. But if we include the uh, spore, what is happening? No, sorry. If we include the spore, it is falling in the normal range, more than fifth percentile. But if we really measure the diaphysis, what is happening? It is falling below the fifth percentile. That means if we wrongly measure, it will overestimating the femur length. Then why we should measure the nearer femur? Because the diaphysis, look at the image, a grayscale image showing both the femurs, the anterior one and the posterior one. The femur that is closer to the probe, the diaphysis is appearing straight, and the diaphysis of the femur that is far away from the transition looking somehow bent, but this is a normal appearance, and due to the medial border of the bone looks such for the further femur. So what is needed, we should measure the straight one, the nearer femur only. And the thing is that, is this image accurate for femur length measurement? And the answer to this is a big no. Reason is that it is actually the plane of section is not properly taken. The femur is first of all not horizontal. It is making an angle approximately 45 degree to horizontal. Both the edges are not that clear, and the magnification is also so poor. So we should avoid this sort of estimation even in raw savar. So what are the advantage of assessing femur? Because femur is the largest of the long bones and easiest to image. It has the accuracy as the BPD in the prediction of gestational age. And when we are not that sure of the LMP for estimating the gestational age, it is very useful for confirmation of gestational age estimation from BPD and or head circumference. And femur as a bone can be measured from the 12 week onwards till term for gestational age estimation, but the predictivity, the predictive value, the accurate prediction gradually falls from early second trimester to the as the pregnancy advances. So what are the key ultrasound features of plan 16? In plan 16, it is an image showing the whole lower limb of one side. First of all, we have to look for uh, the number of the bones present, length of each, the shape of the bone and the segments, the echogenicity, the position and the movement. First of all, this single image showing one thing that the lower limb is present, number one. Number two, all the three segments are present. Number third, all the bone, that means the femur in the proximal, tibia fibula in the middle, and the metatarsal in the foot is visible. So then how to get the plantar view of the foot? So actually what is happening, as it has been seen, the foot and the leg are making 90 degree. So both should be examined from the leg view. When the coronal section of the lower leg is taken, we will able to see both the tibia and femula, and what we are seeing the heel area in a cross section. So if we rotate 90 degree, we will get the plantar view of the foot, because we are when we are in coronal axis of the leg, what we will get is the axial view of the foot, and we will rotate 90 degree, we will get the foot of the coronal view of the foot, and we will ascend upward, we will get the axial view of the leg. So this is an image showing the left one showing the probe in the coronal plane of the leg, and if we rotate 90 degree and slide slightly caudal, we are getting the plantar view of the foot. This is a video from the Mediscan. It has been provided from the basic training. It's showing all the three segments of the lower limb, the femur in the proxima, and the two bones in the middle, and the foot. And the orientation of the foot is 90 degree to the lower part of the leg. So what are the key ultrasound feature of the plan 17? Plan 17 is for the evaluation of the upper limb. The left image is showing the proximal segment, the humerus, the middle segment, the ulna and the radius, and the distal segment, the hand one. And the right image is showing the fetus with the open hand, and almost all the digits is countable from the thumb to the little finger. So these are the basic training videos. The left one showing one upper limb and the right one is another upper limb. And it is important to evaluate both the upper limbs in separate. So,
Samarendra, can you just go back 2 slides and show that Mediscan video of the femur?
Okay, ma'am.
Because there's something which Suresh had told us, and I must share with all of you.
Okay, ma'am.
Femur.
This one. Oh, femur one.
This one. The previous one.
Okay, ma'am.
Yeah. Suresh has said in the pelvic region, you see the iliac bone and the trochanter. In between the head of femur will show like a sunrise, like a angular. There it is. Yeah. So there you put your transducer and just rotate it, you will get the whole of the femur. So you get iliac bone and the trochanter.
Ma'am.
Okay, and in between that there's a bright angular kind of thing popping up like a rising sun. So keep your transducer there and rotate it, you will get the whole femur. And then try to make it horizontal. This was what Suresh had told us. We have beautifully shown that actually. Okay, go ahead.
Okay. So, for the evaluation of the fetal skeletal system, first trimester, the late first trimester is a good time, because all the bones we can see, because all the bones can be seen in one plane. Like in the left upper one is an image, grayscale image showing even at 9 weeks, 6 days, it means around 10 weeks, both the upper limbs at the level of the chest are clearly shown. At 10 weeks, the digits are countable, and the right upper one showing the grayscale image, both the lower limbs. And one thing to note that in the early fetal life, both the upper limb and the lower limb are close proximity. both the upper limbs are placed in front of the chest, and both the lower limbs of the heels are in close approximation in front of the pelvis. This is the beauty of achieving this image in late first trimester, so that we are able to see all the segments in one plane of section. And the lower image are the surface rendering 3D image showing all the limbs in 9 week, 10 week and 12 weeks so clearly. Okay. So after careful assessment of the plan, what are the things we have to search for and to exclude? The number of bones, the length, shape, ecogenicity, the position and movement. All the things we have to evaluate. So what are the things that we can exclude from the number of bones? We can exclude agenesis. In length, we can examine the shortness of femur and other long bone, whether shape is straight or curved or fracture is there. In position, whether normal alignment is there, or any kinds of fixed deformity like talipes or claw hand is present. In movement, we should examine for the movement, whether it is fixed or not, and the echogenicity. In some cases, the bone is hyperechoic, and some cases they were under hypoechoic. So, coming to number. So, in number, what are the things that first of all we have to examine that all the four limbs are present. Number one. Number two, in each limb, three segments to be present. And number third is that each segment, the proper bone should be present. So, what are the things that are problematic in absent limb or segment? Amelia is a condition where congenital absence or partial absence of one or more limbs. Apodia is the congenital absence of the foot. Achiria is the congenital absence of the hands, and there is terminal transverse defect, absence of distal structure of the limb with normal proximal structures. So this is a case, the left upper grayscale image showing a section of the fetal chest, but no section of the upper limb is visible. And on careful examination, even at the level of the four chamber view of the heart, the image, the down image, we are not able to see any upper limb in section even. And this is the post delivery, the image of the fetus, where none of the upper limb is present, but both the lower limbs are present. It is a case of bilateral upper limb amelia. And this is the case of phocomelia, where the lower image, grayscale image showing both the limb bots like things are present, those are the hands, but no definite proximal or middle segment of the upper limb or lower limb is present. This is due to hypoplasia of the hands, because the hypoplasia of the limb, because, so the hands are formed, but it is attached directly to the shoulder. The feet are there, but it is directly attached to the feet are directly attached to the hips. This is a case of phocomelia. The middle one is the 3D surface rendering of the case, and it is a case of absence of the right hand. The left grayscale image showing the middle segment and both the radius and ulnar visible, but the part distal where the hand should be present, it is absent. And in another view, the right one, the left middle segment of the upper limb and the distal segment of the hand is visible, but the right hand is absent. This is the right side AK area. And it is the lower one is a real-time post-delivery image of that baby. And the left image, where the grayscale image, what we are seeing is a middle segment of the lower limb where the tibia is seen and partially fibula is seen, but the leg, the foot part is not seen. This is case of apodia. And the right image, the real-time image of the baby, it is a photo shared by Dr. Santosh Kumar Sahu in real time on 24th of this May. A baby, only one upper limb, another transverse amputation of the upper limb, and both the lower limbs are absent. And the baby delivered by cesarean section 2.4 kilo, and surprisingly the baby has 3 scans elsewhere at some area. And I had posted this here because the skeletal abnormality case are not that rare, and if we will examine, we will get a lot number of cases regarding skeletal abnormalities, number one. And in raw sabar, what is happening, there is we are missing this sort of cases, which is causing the great perinatal morbidity and later on very anxiety in the part of the patient and whole family. So when coming to number of the bones, in the left image showing an image of the radial agenesis and the right one is the fibular agenesis. This is a case of radial ray abnormality. The left image, the right upper limb is shown and the humerus is partly seen, but the middle segment is single bone and the hand is deviated. Comparing to the the right image, which is showing the left upper limb, the proximal segment, what we are seeing is a humerus is seen. In the middle segment, the both the bones are visible, and the part of the hand is also visible. So this is a case of right-sided radial ray abnormality. Only one bone with hand deviation. The larger image, that the left one, the left image showing the left, both the bones are present in the middle segment of the upper limb, but the right side only the ulna is seen. It is due to radial aplasia. Okay. So leading to, this is the graphical representation radial claw hand. In the left upper one, both the radius and ulna is present. And as the severity of the disease progresses, the radius become progressively shorter, hypoplastic, and in the type 4 type, the whole radius is absent. So, and the lower one is showing the deviation of the hand due to radial aplasia, and the upper right image showing the ray area, that means the part of the digit above the radius are the radial ray area, and the part of the digit on the ulnar side are the ulnar ray area. And once when one bone is affected, the radial ray area is also affected by the same process. So this is a case of the left one is a grayscale image of radial hypoplasia, where the ulna is present, which is looking longer than the radius. The radius is present, but it is much smaller and also bent. This is case of radial hypoplasia. And the right one showing radial aplasia, where the proximal segment is showing the humerus, and the medial segment of the upper limb showing only one bone, that is the ulna, and the hand is deviated. And the lower one image showing the graphic 3D image in maximum mode, showing only one bone in the middle segment. So when one bone is present, and that is the ulna, it is a case of radial aplasia. And now coming to another case, this is a case, the upper left image showing a middle segment of the lower limb where one bone is seen, which is right side tibia. The middle one is showing both the tibia and the fibula. So this is a case of right-sided fibular agenesis. And the lower one, the lower real-time image of the baby on the day one of delivery, the right lower leg is somehow shorter than the left lower leg, all due to the bending and absence of the tibia. And also the foot, the plantar view of the baby is showing only 3 digits, 3 toes are present. And this is the X-ray representation, the right one, the X-ray representation of the baby, showing one bone in the middle part of the lower segment, which is the bent tibia, in contrast to the left-sided both tibia and fibula. So the left one is the bent tibia, and the right side of both the tibia and fibula. And if we rotate when in doubt, because at times we are not able to see in one plane both the tibia and fibula, it is a technique to rotate the probe 90 degree, so that in case of fibular agenesis, one bone will only be seen cross section, single bone, that is the tibia, and the lower right one showing both bone in cross section, both the tibia and the fibula. So now coming to abnormality, the diseases which includes clinodactyly, where the deviation of a finger or fingers; syndactyly is fusion, whether soft tissue or bony part of the adjacent digits; the polydactyly, presence of supernumerary more than 5 digits; brachydactyly, which is the disproportionately short finger and toes; erectodactyly is the congenital absence of one or more finger, causing a cleft in the hand or the leg; and clenched hand deformity. So this is a case of clinodactyly, the upper left image showing the small finger with hypoplastic middle phalanx, causing deviation of the little finger towards the thumb. And on further examination, what we are seeing, the baby is having hyperechoic bowel, the renal area showing pylectasis, that means dilatation of the renal pelvis. The heart is showing a central AV canal defect. And on GI tract examination, we are seeing the double bubble sign, the pyloric atresia. And also on CNS examination, we are seeing the nuchal fold thickness is much higher. On genetic evaluation, it came to be a case of trisomy 21. So this is to depict that whenever we are getting a single information regarding any abnormality or anomaly, we have to go further to look for other abnormalities in and around, because skeletal abnormality most of the time may be associated with other abnormalities. It may be isolated also. It may be unilateral or bilateral. It may be syndromic, or other deformity sequence might be there. This is a case of syndactyly, where the fusion of the soft tissue is happening. The image on the left side showing the two fingers are fused, but it is soft tissue fusion, bony fusion is not there. And the right image showing the fusion of the third and the fourth bone, the little finger is normal. And whenever there is syndactyly, there is some degree of deviation of the fingers will be there. So now coming to the polydactyly. Polydactyly is the extra digit in hand or foot, and considering it is of three types: pre-axial, post-axial, and central. When the extra digit is on the side of the thumb, that means the first finger, or the great toe, it is considered pre-axial. And what is present on the little finger, small toe side, it is post-axial. And central means it is around the middle finger. And any extra digit.
Hrithik Roshan has this anomaly.
Ma'am,
Hrithik Roshan, actor.
Yes, ma'am.
He has this anomaly.
Actually, he had a broad thumb, ma'am. Actually, fused one, that is also. Okay. And then soft tissue, or it may also has bony component. So the left lower image showing 6 digit, the thumb on the one side, and extra digit lateral to the fifth finger. That means the left lower image is the post-axial polydactyly. And the upper one, it is showing, the upper image showing, it is also polydactyly of the hand. And the lower right side image showing grayscale, it is post-axial polydactyly of the foot. The great toe is seen, and after the little toe, an extra projection, which is the polydactyly on the post-axial side. And this is an image video from the Foundation of Fetal Medicine showing the pre-axial foot polydactyly and post-axial polydactyly at the level of the hand. This is post-axial, pre-axial foot polydactyly, and this is post-axial. And now coming the syndromic assessment, whenever we are getting polydactyly, whether post-axial or pre-axial, the other system is need to be evaluated, because in this case, after examination, it has come to the kidney, both the kidney, left upper image showing the polycystic, bilateral polycystic kidneys are there, and the head, examination head, there is posterior occipital encephalocele is there, and on examination, it was ultimately diagnosed as Meckel-Gruber syndrome. And this is a case of polydactyly where examination reveals macrosomia, and both the kidneys enlarged, hyperechoic, and the pelvis part is enlarged. It is a case of Bardet-Biedl syndrome. Now coming to the group of polydactyly with some kind of soft tissue fusion, that is the duplicated thumb. The Riti Roshan has this one, ma'am, actually. The thumb is looking broad. There is soft tissue mass, and also the bony component is present inside. This is called a duplicated thumb. Now coming to the brachydactyly, where the fingers are short and looking stubby. The left image is showing the soft tissue of this, all the fingers are looking short and stubby, and the 3D surface rendering view of the both dorsal and the palmar side of the both the hands. Now coming to erectodactyly, where we whatever getting that some one or more finger may be missing, causing a cleft in the hand. The left one is the grayscale image showing missing of the second digit, and this is the right one is the 3D surface maximum mode for the demonstrating the absence of the middle digit, and causing the cleft. Now coming to the cleft foot. Here the left lower image showing a cleft just side to the thumb, great toe, which is the causing the absence of the second toe. And another, the right upper one is the severe clefting of the foot, and its 3D surface rendering view is there, the below one. Now coming to the clenched fist deformity, the left upper one image is showing a hand of one upper limb in a fist-like position. At times, the fist for some certain point of time is not worrisome if it is not permanent one. In case of trisomy and other abnormality, the baby won't open its hand even after repeat the examination. If you repeat the examination after 15 to 20 minutes. So it is a fixed, clenched deformation where the thumb is looking normal, but the second toe is deviated and causing overlapping to the third digit. The fifth and the fourth and the fifth digit are in a fixed position. And the lower one is the image from the upper side showing the deviation of the second over the third digit, and the right sided two images in sepia mode showing the overlapping of the second over the third digit from the palmar side and on the dorsal side, the fist, and the middle lower one is the after delivery postnatal image of that clenched fist. It came out to be case of trisomy 80. Then coming to Hitchhiker thumbs, where the thumb is abnormally abducted position is present. It was a case of actually dystrophic dysplasia, and the left image showing grayscale, the thumb is actually far away from the other the digits, and the right one image showing the 3D surface rendering that the thumb is present far away and it coming not coming close to even after repeat examination. That is a case of dystrophy dysplasia actually. Now coming to the sandal gap deformity. The upper left image showing there is a gap, specific and permanent gap between the first toe and the second toe. Eh, and all the digits are, all the toes are present, but the gap is, prominent gap is present. They call it sandal gap. In the lower image, showing the normal foot, where actually no such huge space is present from the in between the first and second row, and the right upper and lower image showing the 3D surface rendering of the toe. Now, now coming to limb reduction defect. It is a terminal transverse limb defect, more common in upper limb than the lower limbs. It may be isolated or part of the syndrome and are likely to be associated with other abnormalities, result from avascular injury or coagulation defect. And the many cases are the cause of the constriction band sequence, or the so-called the amniotic band sequence. So in case of amniotic band sequence, what is happening? There is early rupture of membrane, which is the amnion, which will cause the formation of the fibrous band that can trap, constrict, or disrupt the fetal part, leading to limb amputation, deformity. It may involve the cranial part causing the encephalocele, the face area causing the clefting of the face, or the ventral body wall causing the gastroschisis. And to be the characteristic feature is the disruption are usually asymmetrical. So the left upper grayscale image showing and middle segment with radius and ulna, but the distal hand part is absent, and the right upper one showing the 3D surface rendering, and the lower one showing the 3D maximum mode with the bones, where the hand is missing. And on further examination, we are able to see the lower grayscale image, we are able to see a band of the amniotic membrane coming from the surface of the uterus to the affected area, the upper limb. And the right hand is present and the left hand is absent. And on further examination, it was found that the abdominal area showing gastroschisis, the protrusion of the liver and the bowel area from the abdomen, and the right upper image showing the postnatal, the digits are partially amputated, and the lower image, lower right image, this image is showing there is constriction band at the middle of the uh, middle segment of the upper limb.
Amrendra, it is omphalocele, not gastroschisis. It is omphalocele.
Actually, sir, I also cross check, but it is the liver herniation, sir.
Yeah, but that is in omphalocele. Gastroschisis is all the intestines will come out.
Oh,
This is
okay, okay, sir, okay, sir. And the right lower image showing a midline cleft like gap due to the constriction band is formed by the fibrous amnion. Now coming to the abnormality of the length of the limb, the shortening of the extremity that can involve the whole limb or a segment. When the whole entire limb is short, it is called micromelia. When the proximal segment is short, it is called as rhizomelia. When the middle intermediate segment is involved, it is called mesomelia. And the distal segment, it is called acromelia. So the left upper image, grayscale image showing a femur which is looking bent and short. This is proximal, the rhizomelia part. The right upper image showing the humerus and the radius and ulna and foot. And note that the length of the radius and ulna is looking disproportionately smaller to that of the humerus. It is a case of mesomelia. And the lower image is showing it is case of the shortening of the whole limb. It is case of micromelia. In length, in the short femur, The causes are multiple, out of which the trisomy aneuploidy, fetal growth restriction, skeletal dysplasia, and in syndromic anomalies, these are the most common causes of short femur. But we have to rule out the constitutional one. And the when we are getting one femur small, we have to examine all the long bones and take the objective measurement of the all the long bones. But when we are observing that one bone femur is normally length, we should also examine the other femur, because when some cases of unilateral shortening of the femur also do happen, and it in case of proximal femoral focal hypoplasia, which emphasizes the examination of the both femur, and we are, if we are lucky, we can get in one plane of section if the baby has maintained its position. The left lower one showing one femur normal, and the other femur is no doubt smaller and also looking curved, and the right lower image showing normal proximal the femur, and the femur that is far away from the pove is looking smaller but is straight one. Now coming to the shape. In shape, what we can observe whether it is short or curved. The images showing, the upper image showing grayscale image, the left one curved femur, and the right image showing a straight femur. Now, whenever we are seeing curving, we should search for any kind of fracture is there. The left image grayscale is showing it is short and curved, and the right image showing short, curve, and also fracture is also there. Now coming to the position. In position, we should look for the position of each segment in relation to the other proximal segment, and position in relation to the other body part. So the left upper image showing a normal lower limb image where the femur, tibia, fibula are present in slight flexed condition, and the foot is present or at a 90-degree in normal orientation to the lower leg. But the image just below it showing a plantar view of the foot, and in the same image we are able to see the tibia and fibula in coronal section. And in real sense, whenever we are getting the tibia and fibula in coronal section, we should not able to see the plantar view, because we have to rotate for normally see the plantar view. And if we are getting in the same plane the tibia and fibula and the plantar view, that means the foot is rotated. It is a case of talipus, claw foot, and the right lower one showing the 3D surface rendering of that claw foot. It is the other images of the claw foot, the images are. Now the position, the movement. In every baby, we should examine for the movement of the limbs, because for movement, what is needed for a gross body movement, it is a part of the biophysical profile scoring, and in any examination there should be 3 gross body movement for in our 30-minute examination, and simultaneous body and trunk movement should be counted as a single movement, and we should have the trunk rolling, and in case of limb, active flexion extension movement should be there. And for movement, good amount of amniotic fluid around the baby is necessary, and good neurological and musculoskeletal coordination should be there. If fluid of, around the baby is less, the restriction will happen, or if there is any vascular, neurological, musculoskeletal abnormality is there, then fetal movement will be reduced to absent. So this is a case of genu recurvatum, where initially in initial phase of ultrasound, the right upper image is showing both the lower limbs in one position. Both the middle segment, the right upper image show both the legs in same, we are getting same plane, and this one showing both the femur in one plane. But as the pregnancy advances, what is happening in later part, the lower right image showing that only one leg is seen in that area. So after careful examination, what is happening, the other leg is seen hyperextended left upper one, hyperextended as if the feet is touching towards the fetal face, and it is a case of genu recurvatum. So because of the hyperextension at the level of knee, there was reduced movement of the baby, leading to atrophy of the muscles of the leg in around. And this is the middle one is the postnatal image of that baby. One limb is normal flexed position, and other is hyperextended, and the foot is almost at the level of the face. This is a case of genu recurvatum. This shows that in case of reduced mobility, there will lead to some kind of contracture at the knee joint. It might be due to either knee dysplasia, or it may happen if there any quadriceps muscles contracture leading to hyperextension of the knee at one leg. Now coming to akinesia dysplasia fetal syndrome, where there is prolonged decreased absent fetal movement leading to fixed abnormal limb position, muscles, pusity, craniofacial abnormality, IUGR, and pulmonary hypoplasia and polyhydramnios. So this is a case, the baby was not moving. In a scanning, the baby was not moving. Hello. On gross examination, even for 30 minutes, there was no movement, and this case was showing polyhydramnios. Okay, fine. And on examination, it has been found that the muscles around the bones in both the lower limb, it was the wasting was there. It should be somehow convex. The shape of the muscles around shown wasting. So also in the left upper image, it has shown the heel is unduly prominent. It is rocker bottom foot position. And in case of face, there is, we are also able to see the mandible in the face, the sagittal plane of the face, showing the mandible is in a retrognathic position. And in the right lower image showing the upper lip, where there is a band of skin which showing the contracture that has been developed due to loss of mobility of the baby. Now coming to arthrokyphosis, where there is multiple, in the case of where in real-time exam there is absence of movement will be there with severe flexion deformity around, leading to contracture, flexion of the limbs and hyperextension of the limbs, and deformity are typically symmetrical involving the four limbs, and growth retardation will be there. In many cases, you will get oligohydramnios, but when you will get arthrokyphosis polyhydramnios, the prognosis is really poor. This is a case of arthrokyphosis where there is fixed deformity due to contracture of the lower limb at the level of the knee and also at the level of the ankle. And the baby is not showing any type of gross movement, even at the level of the hip, at the level of the knee, or at the level of the ankle. This is a case of arthrokyphosis. Now, these are the 3D view showing the arthrokyphosis, the hand, the left upper image showing surface rendering of the hand in a fixed contracture. The legs, in the leg, the foot is extended, and these are the correlative postnatal image of the hand in a fixed contracture position, in flexed position, and leg in a foot in extended position. And this is the left upper image gray scale showing the extended lower limb with deviation of foot both side, and the other image showing after being repeat examination it won't showing any gross movement, and the extension is permanent one. So also the claw foot is there. It is the 3D rendering showing a fetus, the extended limbs, lower limbs, and the flexed fixed contracture of the both the upper limbs. And it is another view of a grayscale, the right upper one, where the knee is extended at the level, the leg is extended at the level of C. And so also observe that due to congestion, the foot, the plantar arch is looking everted, a rocker bottom foot is present. And the lower right side image showing both the hands in fixed contracture at the level of the elbow. This is a case of rocker bottom foot where the uh, foot, the plantar surface is not looking flat, rather it is everted. And this is the 3D rendering, the rocker bottom foot, where the heel is also unduly prominent. Both the heel is prominent, so also the plantar arch is looking everted. And there is now come to echogenicity. In case of skeletal abnormality, most of the cases there is reduced echogenicity, and some cases of increased echogenicity also found where there is premature ossification of the carpal and the tarsal bone occur, like chondrodysplasia punctata and fetal alcohol syndrome. So the key point is that we have to identify and examine the plan 15, 16, 70 for pathologies of the limb. Always check for the bones, shape, position and movement. Our role is to distinguish between normal and abnormal, and whenever we are getting any abnormality, we should refer the case for further systematic evaluation in a standardized approach, and the all system of the baby should be examined, including fetal echo, for expert opinion. There is a huge
Yeah,
and
wait,
sir,
wait.
sir, the sound is not that audible,
I
sir.
think you stop at key point, and yeah, you stop at key point and go to your last, because all the skeletal dysplasia we will be sharing in a special. This will be too much for basic. Go to
Okay.
the last slide. Go to the last slide.
Oh, okay, sir. Okay.
Go to take home message. Go to take home message.
Okay. Okay. So after examination of all the plans, all the four long bones with all the three segments should be evaluated properly. The fetal skeletal structure being echogenic are the earliest recognizable structures, and their sonographic evaluation is highly dependent on the position in later part of the gestation. Any abnormality detected needs urgent referral, and if it normally is detected, a complete fetal ultrasound evaluation, including assessment of the fetal movement, should be performed. If a skeletal disorder is suspected, but still, in spite of advances, the prenatal diagnosis and management of the limb abnormality is complex and require a multidisciplinary approach. Thank you, sir.
Thank you.
Thank you very much,
It was a very elaborate talk.
Extensive presentation, yes. At least it was a very good presentation. And of course, we should not forget that we are building up a basic knowledge about things. So too much advanced things may be a little overburdened to the specialist. It's okay. It's in a different forum that we will speak. And a question to you and Sasmush sir. What is the incidence of sirenomelia? I mean, when all the limbs are together, a mermaid baby. It's a very rare thing, but sirenomelia.
Very rare thing. At least I haven't seen one, you know. Right. Sirenomelia.
Your comments, and then we will go in for the post poll. Any
Yeah,
questions
I
and
think,
answers
yeah,
from
let me,
the listeners? Any questions from the participants? Please unmute and ask. Yes, it was indeed a good presentation, very thorough.
Ma'am, participants may also post their questions on the chat box.
Yes, post your question in chat box or unmute and ask.
right. So thank you. Thank you, Samrendra. I just asked you to stop because skeletal dysplasia is a very special chapter.
Sure.
And also it is a very advanced thing, and let us, I wanted to confine this to the basic.
Okay,
So thank you so much. Your slides were
welcome.
excellent.
Thank
Excellent,
you.
actually.
Thank
Yeah.
you.
And to summarize what I would
Participants
like.
should not be, if you cannot get the right planes on during on-site visit, all these different steps will be demonstrated to you. The sliding from plane 15 and 16 and all those things. Okay. How to focus the digits.
This is very easy. Actually, if you can imagine where is your position of the limb, accordingly you have to turn the transducer. To see the limbs, you go to the longitudinal part of the limb, and then you can see the hands and fingers. If you are not able, slide a little bit and angulate, not too much, but everything it depends how much you are angulating and the what is visible. It is a probe movement. I think this can be shown to you on site only. It is difficult to describe. I think on site it will be very easy to describe. And to summarize Samrendra's talk, what I would like to comment means what I do is we try to look at the extremities in the first trimester itself, because it is very, very easy. You can see all the segments because there is more liquor. The fetus is not too big, and there is a lot of space in the uterine cavity, and fetal movements are there. So it will come into view, all the limbs, all the segments, including the fingers, digits, and everything you will be able to see because the fetus is moving at that time. It has a lot of space there. And we had a last time, Madhumita Mahanti very clearly told us that whenever there is enough liquor, first what we do, first we do look at the liquor, then we look at the bladder, and then we look at the kidney. So if there is adequate liquor, we will definitely see a normal fetus will always be moving a lot. This is if it is not moving, there is something wrong. Suspect if a fetus is there in a constant position and not moving, we have to wait. Sometimes we have to wait, and we can even I had instances when I have to recall the patient that come tomorrow because your fetus is right now not moving at all. So either they go for a walk, move around, or come next day. This has to be there. And as I said, in case of obese patients, it is always the first trimester is much better because the uterus and the fetus has not come up to the abdomen. It is still in the pelvic cavity. So there is not much of adipose tissue, which is a hindrance to the ultrasound beam. That is one point. In the second trimester, also we can elaborately, when we are doing a mid-trimester scan, we make it a practice to see everything, as because a lot of cases can be missed if you don't see all the segments. And of course, flexion and extension of fingers has to be seen. If you see a fetus in a clenched fist, the fist is clenched one and not opening the hand at all, we suspect trisomy 18. That is one of the feature. And of course, as Samrendra has already elaborated, that when you see one abnormality, we look for more and more and more, because a constellation of finding will always be there in case of some syndromic thing or genetic trisomies. Trisomy 13 and 18 are the most easiest to detect, because there will be a lot of abnormalities. These fetuses you can diagnose very easily. It is only the trisomy 21 which is a very challenging aspect, and that deceives us many times. So this is all I had to say. And madam, if you want to, is Preeti Dubey there? Preeti?
Yes, sir. I'm there, sir.
Yeah. Preeti, I would like you to comment.
Your comments, please, Preeti. Unmute and show.
Yes, sir. Actually, it was an extensive presentation. I don't think he has left any point. But what Hasmukh sir has told, it is very important that we need to see the limbs in the first trimester first. Okay, because in the first trimester, baby's limb, opening of hands, and the talipus in the foot will be clearly seen in the first trimester. So that is very important. Whenever you have an opportunity to see the baby in the first trimester, please see all the 3 segments very well. And rest, I think anomaly scan, Samrendra has covered very extensively. It was a beautiful presentation. I don't think I need to add any point.
Thank you, ma'am. Thank you.
Yes, indeed, Preeti. Samarendra has done a wonderful job, and people are appreciating in the chat box, you can see. And so, shall we go to the post poll immediately so that the questions can be discussed?
Yes, ma'am, sure.
Post
If
poll will
any
be launched
participant,
now. Everybody, please don't leave. Please see how much you have improved from your pre-poll.
madam, if participants have no more questions to ask, then we can directly go to the polls.
Yes, we'll go to polls.
Yes, they are also requesting to go to the polls. So Hashmukh sir, let them answer first. After they answer, then it will be discussed. Quick, post polls have been launched. All of you tackle them. I think all of you must get everything right this time. Quick, only 0% have participated. What's happened? Everybody's gone off to sleep. Post poll questions are launched now. Come on. Start answering them. Very good. Question 6. Which of the following statement is false? Don't select the true answers. Which is false? Correct yourself. Read the question properly. The best response you have to pick up. It is asking you which of the 4 sentences are statements are false. Which one? Again, rethink about question 7. Which statement is false? Don't choose the true question statement which is true. Don't choose the true statement. Choose the false statement. False is the best response. It's the best response, but it is false. Very good, Tapan. Submitted.
Thank you, madam.
Tapan is in Junagadh, no?
Yes, madam, at Junagadh.
Any more PPH cases? Are you using
No.
non-pneumatic anti-shock garment?
Madam, ebe jao tapra dorkar padini fortunately.
Very good. Dorkar padne mane you are doing good obstetrics. Dorkar padile kintu ago bandi paku.
Yes, madam. Yes, madam.
We don't want any PPH deaths.
Tapan is at Junagadh.
Yes, sir. I am at Junagadh. Sir, namaskar.
Namaskar. Acha.
Yeah, Bhavanipatna.
Yeah, your patient shouldn't come to Titlagarh.
In difficult cases, I will.
Tapan, have your ultrasound patients increased after this training?
No, madam. Patient flow is as such, but
you're not attending regularly. Huh?
Then I am attending regularly every lecture.
And is it not improving your scan?
Yes. It madam बहुत very improve करूँ madam.
Madam on-site जामे जिबु जे on-site जिबु.
Yes madam. बहुत helpful होच madam.
गोड़ा उड़ाटे भला ही जब. I'm not allowed to move out for 3 months.
आज्ञा madam. शीघ्र भला ही जिबे अपन समस्त कर good wishes आपन सहित सब बेले अछि.
I can feel it actually. Lot of goodwill.
Madam, आसिले टिटलागढ़ आसीबे टिटलागढ़ रु आमे समस्त मिसिक जिबा.
Yes sir.
I'm a physiotherapist मना कला कला अपन long tour करि परिबेनी before 3 months.
Right.
Come on, quick. Let the percentage go up. Only 44%.
Yeah, replying B as the correct answer, but I think there was a beautiful slide by Samarendra saying that, yeah, I don't know, Miss, why they haven't seen or heard or what.
No, he has the question is false statement, which is false.
Yeah, I think spur on ends is the false one.
So that is the best response.
Yeah, okay, that which one is false? Yeah,
best response.
Best response. Okay, best response. Thank you.
Have you got duty? Before you leave, answer the polls and go. But if you leave, you will not be able to know the right answers. ठीक answer
Madam, there is a question from Narottam Bhai in the chat box. Can amniotic band syndrome cause late onset skeletal deformities, abnormalities?
Yeah, amputation have a amniotic band syndrome can constrict and the limb can be amputated. Yeah, it evolving have a yes. Preeti?
Actually, amniotic band syndrome is always late onset only.
Yeah.
Very rarely it is early diagnosis. So usually it exists only after T1 scan. In the third trimester, you will see that there is amputation. Then you see a band-like thing which is very closely attached to the limbs. So you can suspect amniotic band at that time. And usually it causes a part of the finger, or it can cause a limb, the whole limb, or it can cause both the limb depending on the side where the amniotic band is there. So it is always late onset only.
Does it have a genetic
No,
background?
madam, no genetic
No.
predisposition.
So there's some injury to the amniotic membrane.
Yeah.
Which
Yes,
hangs
madam.
up and then forms
They
the
are having some, due to some chemical reaction, the amniotic membrane, they got cleansed together and they form a band.
So, madam, skeletal evaluation also should be done in third trimester also.
Yeah.
Yes, if you
Yeah.
can
At
observe.
any time of, at any period of time, at any period of gestation, if the patient has come to you, please evaluate the patient thoroughly from tip to toe. Because you cannot mention that I've seen this. You are legally liable even if you do the scan at 33 weeks. Even now I'm seeing a patient of 37 weeks, 3 days, they've referred for second opinion. I try to see each and everything. I cannot dispose of by telling that this is advanced pregnancy and I'm not responsible for the thing. Whatever possible you see, and what you cannot see, you mention in the thing that despite all efforts, that the fingers limb deformity could not be imaged due to advanced gestational age and fetal position. That you can write. But whatever you see, you write. Both kidneys seen, whatever you have seen, you write from head to it till the skeletal system. Whatever thing suppose you have seen the head, intracranial structures well seen, posterior fossa seen. So one line, two line, whatever you have seen, you have to write. You are not excused because the patient has not come for TIFA scan and you have missed a gross anomaly. Gross anomaly should not be missed. So please try to see whenever the patient has come from top to bottom, just move your probe and try to see everything.
And also mention what you have not been able to see and you have attempted
Yeah,
to do.
because
And you can refer this case to expert.
5% of the anomalies, they appear in third trimester.
Yes, sir.
5% of the anomaly, they appear in third trimester. So that's why we will look.
After the patient deliver, after delivery only detected the baby has a limb abnormality, one hand, some
The
finger
following
missing,
statement,
and one foot also, half of the
Please
foot
be
is
louder.
missing.
I think somebody is interrupting in between.
Madam, last year one delivery occurred. The after delivery, it was found there the baby has absent some fingers of one upper limb and half foot in left side, half foot is also missing. But no other
Actually,
skeletal abnormalities.
foot you can see clearly in the scan. Yes, finger abnormalities we cannot see, but the recent guidelines of ISUOG, which is released in 2022 about mid-trimester scan, they have asked us to see the fingers as well. They told that it is not mandatory, but it is our duty to see all the fingers. Usually I try to see all the fingers in my 7 years of this 10 years of practice. I have detected nearly 3-4 only hand finger abnormality. The one
But they
patient
can it be prevented antenatally?
Pardon, I couldn't get you.
He's asking, can it be prevented? Is it Narottam? You are asking, can it be prevented? What is your question?
Is it preventable?
What
Like
prevention?
Selected abnormalities, can it be preventable?
You can detect earlier actually, and just look for what is the cause. Is it any associations are there? Is it syndromic? Is it related to some kind of positional? Because sometimes in oligohydramnios itself also you can see some because of the positional thing, pseudotalipes or something. So I think it is a thing you can detect earlier. We cannot prevent if something is going to happen. Yeah. Narottam, you are in Jasi. Narottam, you are in Jasipur. Is it you said? Is it Jasipur?
Yes, sir. Yes, sir.
Yeah, you are in Jasipur, Mayurbhanj. Yeah. Okay. Nice
Hello.
place. Yeah.
Near to
Hello.
Khairi.
Madam, I have a doubt.
Tiger.
If suppose you detect a case of isolated clubfoot, is it a indication of MTP? Should we terminate or not?
No. Isolated clubfoot is correctable deformity. It can be corrected after birth. So what you need to see is whenever you are finding a clubfoot, you have to see the intactness of the spine. What can cause clubfoot? Either it is a spinal abnormality or partial arthrogryposis.
And unilateral or bilateral, that also.
Yeah.
Unilateral
So only these things you need to rule out. For spinal defect, you need to see the entire spine with the skin intact properly. And to rule out arthrogryposis, you need to see the movement of all the joints. If you have seen those things perfectly, and if it is a confirmed case of isolated talipes, you cannot terminate the pregnancy because it is a correctable deformity.
Thank you, ma'am.
There's a joke, one of my relatives, I had done a scan, bilateral talipes was there. The grandmother told me, didn't you detect, when it was born, it was there. I was not such an expert at that time, now, but then I was using LNT machine, and then she said, didn't you detect it inside utero? I said, if I had detected, would you have operated on the baby? So it is a non-lethal anomaly, and of course it was corrected, and that boy is doing fine and doing very well in studies and gone up.
Yeah, there are many correctable, and also it depends on, like here in our situation, it depends on what kind of resources we have for support. Let us say cardiac anomalies. Some cardiac anomalies in United States, they will not terminate because treatment is available. It will be delivered in a tertiary center and the newborn will be operated. So it depends on how much of money someone has, how much of resources the community has, how much of infrastructure is there. Everything depends on that actually. Say for example, spina bifida in Texas hospital, Magdalena Sanchez, is her name. She does a lot of spinal surgeries also and in intrauterine. They do. There is someone in Mexico also, one lady is there, Dennis, is her name. She also does a lot of correction on spina bifida. These are the authorities. So it depends on how much of resources people will have. Like in our setup, the parents cannot afford. The cost will be very high. Yeah.
Here we have a RBSK, Rashtriya Bal Suraksha Karyakram. When congenitally malformed babies are born, entire cost is borne by the central government. So
It's
many
true, madam,
have
but
been
how many?
yes,
Yeah.
Rashtriya Bal Suraksha Karyakram. So this information must be given to those in whom you detect these kind of anomalies, especially cardiac or neural, whatever. Even clubfoot, if they have, this treatment is totally free from in this scheme.
Cleft lip, cleft palate also. Cleft lip,
Yes, cleft lip also. The SMILE program is there.
Yes, madam.
And the RBSK meets it. Yeah, we have an RBSK manager here at SCB who's doing a good job. All the referred cases from the districts come and he nicely coordinates their treatment and everything.
Right.
Madam, RBSK managers are posted at all district level through NHM.
Yes,
and they cater all abnormalities, including higher range cardiac and anomalies also.
So this information must be given to the patient so that they don't delay. Right at the outset, when you detect something, you contact the RBSK manager and
Madam, if the RBSK manager is not available, then they can contact the MHU team. Those are traveling their villages, and the DEIC clinics at district level, district early intervention center clinics.
Yeah.
Yes.
Samrendra, how much of information, this type of information is percolating to our public? Tell me, in Balangir district, what is the situation?
There are two teams, MHU and MST team, and under RBSK, they are moving around all the villages and making all the patients aware, and they are screening also for any kinds of anomaly, and their referral is going on every on I think Wednesday and Friday. Those people are referring those patients to CHC, and after contacting with the higher institution like we are referring from CHC to the higher institution for any kind of operation, like cleft lip, clawfoot, all these are going on, sir.
Yeah, my question is the
public, the three big medical colleges, especially SCB, all these cases get referred.
Is the public?
They are helping, sir, very good team approach for this anomaly detection.
Yes.
Public awareness heichi amara Samrendra, public awareness.
Yes, yes, sir.
Even eye operation bhi hoche, sir. Bhubaneswar LV Prasad re eye operation also going on. Some in this cleft lip, plus our government medical college bhi hoche. Everything is going on, sir.
Good. Right.
So now, shall we end the polls and see the results? 95% participated. So, Dr. Hasmukh, sir.
Yeah, I will just read out. So, question number 1: spur on ends of diaphysis are included in the measurement. Yeah, that is the correct answer because that is a false statement. So B is the right answer. We have to measure only the diaphysis only, and the femur has to fill 50% or majority of the screen. So B is the correct answer.
And what is the jump from pre to post pole?
Pre and post orientation pole jump is from 65% to 93%, 95% to correct response.
Very good.
Good.
So
good.
Very good. At least 65 have done correctly, but 95 jump is very good. Next question, sir.
Next one is which of the following statement is false? Question number 2: full thickness of femur diaphysis is visible sonographically. That is the right answer.
No, it is not false.
So, Samarendra, what is your take on this? Which one?
Actually, as the pregnancy advances, only we are seeing partial thickness of the diaphysis. Length we can see, but thickness is getting partial with the advances.
I think he had a beautiful slide he showed actually. He had a beautiful slide.
So the best response is A.
Ma'am.
Sir, but the question
They were confused.
demands that which is the false
answer
statement,
shows
not the correct
they were
statement.
confused. So please explain
The
this
question is
particular
that
phenomenon
which of the
once
following is the false statement?
Which is a false one. Okay. Okay.
Yes.
A short femur is an abnormality and the criteria of referral, that is right. Measurement of femur is done from entro-external side. This is also right. Orthogonal approach is best for fetal length measurement. Samarendra, tell me what has happened on this.
The best response is the question which is false. Because we have been asked which is the false question.
False. Ma'am, actually option B, C, D are correct. And regarding option A, the full thickness of the femur diaphysis is not always visible in during scan.
If you instead of false, if you had said which is not true, probably they would not have been confused. No.
It is direct statement, which is the following false.
It is not true. That means the first one is not true.
Okay.
So that is the best response. Best response need not be the right answer. Best response may be the wrong answer. Wrong response. Okay. Sorry. Best response is the false answer. Others are true. We don't want you to select the true ones. So it is just a brain teaser. So post and pre-poll.
Madam, post and pre orientation poll difference is from 21% to 36% for this 37% for this response.
Some of them have understood. Some of them have understood.
Yes, ma'am.
Good. Next.
Now, question number 3 is true statement regarding the key ultrasound features to look into the bones are we look at the length and shape, we look at the echogenicity, we look at the position and movement. So all of the above is the true. All of the above. D is the right answer.
Pre and post poll?
Madam, pre and post difference is from 98% to 100%.
So this is an easy question. Very good.
Yes.
Okay.
Next.
So number 4 is false statement regarding evaluation of bones of the extremities. So we can suspect or rule out skeletal dysplasia. That is right answer. We can rule out flexion deformity. We cannot rule out IUGR. That C is the right answer, because IUGR also is a feature of short bones, right? So
especially early and post orientation will have a short femur.
Yeah. 98%.
76% to 98%, madam. 76% to 98%.
This is a good jump.
From pre and post. Madam, आपण कोण कहूଥିଲେ मु मझरी इंटरप्ट करली.
मु कोन किछ कहन नहीं नहीं जो IUGR रे. Early onset IUGR can be detected by the length of the
short femur. Yeah, short femur. Yeah. Number 5, which of the following statement is or are true? So which one?
Everybody has answered correct.
D is the right answer. D is the right
Everybody
answer.
100% correct.
Yeah.
Pre-poll?
Madam, pre and post orientation difference is from 95% to 100%.
Yeah.
Oh, good. At least 5% got cleared.
Right. Which number 6? Which of the following statement is false? A is false. A is false because tibia, fibula, and plantar surface of foot should be visible in one scanning. Plantar surface cannot be visible in the same plane actually. So A is the false statement.
Best response.
Yeah.
Best response is A because we want to select the false one.
Right.
Then pre-poll.
Pre and post orientation difference is from 52% to 72%.
Good.
Good one.
So at
Good
least this point was clear to quite a few.
Right. So number 7, which of the following statement is false? Number 7, C appears to be false because curved bones are not a normal finding. As he has beautifully shown a slide. curved bones are a feature of skeletal dysplasia actually. So
Telephone
C-
handle femur.
Yeah, yeah. C is the right answer.
But pre and post difference is from 52% to 68%.
Good. It should have been a little more, but then it's okay.
Right.
Next question.
Number eight. Number 8 is good fetal movement are reassuring for. D is the right answer because good fluid is, it will be a good fluid, good flexion and extension movements, ruling out fixed flexion deformities, good neuronal and musculoskeletal coordination. We can also think that yes, all the synaptic places are very well coordinated, like nerves and muscles are very well synaptically united. So all of above is the right answer.
And pre and post difference is from 9. So difference is pre and post orientation difference is from 97% to 100%.
3%. Okay, 3% were unclear, no? Before. Good.
Question number 9. Which of the following statement is false? I think there was a beautiful slide of he has very which are the long bones. There was a slide by Samarendra. Carpal bones are not long bones, you know. So B is the correct statement. Correct. B is the false one. Long bone of upper extremity includes humerus, ulna, radius, and carpal bones. Carpal bones are not long bones, so it is a false statement. B is the right answer. B, the correct response should be B. Hello?
Pre and post bone?
Pre and post difference is from, madam, 42% to 67%.
So good jump. Still, why was somebody more than that unclear? I don't know. Very clearly it was described in the presentation.
Yeah, I think the slides were extremely very good. I think Samarendra
I think those who joined late, it was they who have not clear. Otherwise, those who have attended right from the beginning, definitely they will have made a correct choice.
Samarendra happens to be a prestigious member of our Society of Fetal Medicine. He also presented a beautiful poster. So he is very young, energetic, and always in command. I think someday we will see him leading the SFM in Odisha.
Sir, your blessings, sir. I will travel even.
Thank you. So question number 10 is small femur length below 5th centile points to. Below 5th centile. This was also, he had a beautiful info on a slide. It can point to skeletal dysplasia. It can be a feature of Down syndrome. It can, and madam also just now told about a short femur, that early fetal growth restriction femur is short. So all of above should be the correct answer actually. All of above. And 98%. Yeah, good response.
Pre and post bone?
Pre and post difference is from, madam, 90% to 98%.
Good. Yeah, lovely.
Very good.
So yeah, it is a beautiful presentation today, and very, very successful day we had. And we are now, you know, next presentation is by Dr. Ajit Naik. He will present on making a decision normal or not. And also Dr. Preeti has to do one. Today we are short of time, but Preeti has a set of slides where she is going to show, because we have seen all the 20 planes and the 50 anomalies which could be easily identified now by all our trainees if they have attended right from the beginning. 50 anomalies can be easily, you can say, and these are very easy. Why? Because I will tell you what happens. We are seeing 95% of the scans, we will see the normal pattern, because 95% of our fetuses are normal. It is only in 5% cases we find some abnormality. So instantly, because we are seeing so much normal, that any abnormality will be instantly picked up by your pattern recognition, our brain, you know. You will instantly know, okay, this is not right. There is something wrong. So this one aspect is first thing is we have to decide this is not normal, and then what is the abnormality. We will take you more and more to the depth of the subject, and we stay connected for a long time. It is not only now, but we are committed. I said in my post in the virtual training also, that we are committed to make all these interested obstetrician as expert as any sonologist. I think you at your level, and as I said, Tapan, you should not refer any cases to Titlagarh or any place. You be up to go up to that level. And I think this is yeah. So thank you so much. And madam, please go ahead with your comment. And Preeti, if you have to share something.
Comments, please. Preeti, before everybody leaves. Hello, Preeti. She's left.
No, madam.
The last advice to our obstetricians. I mean, for this session, of course.
Yes. I think we need to see all the three segments in systematic manner. Like if you are seeing the upper limb, we need to see the humerus, radius ulna, and all the 5 fingers. Try to see all the 5 fingers in both the hands. Because if you try to see only, then only you can see the missing fingers and all. Otherwise, you will never able to see. It is not there. That finger abnormality is not mandatory. If you think like that, you will never able to pick up. So please try to see open hands in all the cases. And in lower limb, you would see that angulation to rule out talipus between the foot and the lower limb. That is in tibia and fibula. That 90-degree angulation is mandatory in the present ISO guideline. Previously, it was not there, but in this guideline, mid-trimester guideline 2022, it is mandatory that we should note that lower limb and the foot should be there at the angle of 90-degree to rule out talipus. So go through the new guidelines and try to see each and every structure before you give a report as normal. Thank you, madam.
Yeah, and I will say a few more words. We have got a SFM webinar monthly meeting. Samrendra is going to share one more topic. Marker. Yeah. Rama Manjari is also talking on aneuploidy screening. And we have one more speaker from West Bengal, from Kolkata, Devasmita. Devasmita is.
Devasmita, yeah. So we can post the link in the group.
Yeah.
Blood, baby blood collect genetic test तार जेनेटिक जीन ता खराब थिबो ताले आरो बेबी को भी हेबारो चांसेस थिबो हैला से जेनेटिक टेस्ट का मु लिखि देबी आपन जो भी डिलीवरी करेबे ताको कहबे.
Okay, Preeti is working. Preeti is working in the clinic.
Talking to our patients, counseling.
Yeah. Anyhow.
Okay, then we end, sir. Thank you very much
for. Okay, thank you so much. Yeah.
Very much, Samarendra, for a very exhaustive.